Okay.
There we go.
Thank you. Okay, well, evening, everybody. I'm Ben Coleman. I'm a councillor in Hammersmith and Fulham, and I'm the Cabinet Member for Health and Adult Social Care. Welcome to this evening's Health and Wellbeing Board. That's the body that brings together the NHS, the Council, and lots of stakeholder other organisations, police and others, Hammersmith, Fulham, Save Our NHS, people who attend, people who are board members, to talk about lots of matters relating to improving and maintaining the health and wellbeing of the borough. I'd like just to go through, I think we've got a manageable amount of people. We'll go through apologies and things in a minute, but I'd just like to go around the room, virtual room, so as it were. So just give people a chance quickly just to say, if you wouldn't mind saying who you are, organisation you represent, and I'm going to do it in the random order in which people have presented themselves on my screen. So Joe Beatty. Joe, if you just say who you are and where you're from, as it were.
Hello, Councillor Coleman, already technically challenged. Good evening, everybody. I'm Jo Beatty. I'm the Assistant Director in Social Care with a responsibility for specialist services, that's mental health and learning disability and independent living.
Thank you. Lisa, Redfern.
Hi, good evening, and hope everyone's had a nice summer. Lisa Redfern, Strategic Director for Social Care with responsibilities for public health and voluntary sector as well. Hi.
Thank you. Lucy Richardson. Lucy, you're on silent.
Sorry, it was just taking a while to respond. Good evening, everyone. My name's Lucy Richardson. I'm a councillor at Hammersmith and Fulham, and I chair the Health Committee.
Excellent, thank you. Nicola Lang.
Nikki Lang, Director of Public Health.
Great. Linda Jackson.
Good evening, Linda Jackson, Director of COVID-19 for the Council.
Thank you. James Kavanagh. You're on mute, I think.
Yes, I was. Hi, my name's James Kavanagh. I'm a GP in Hammersmith and Fulham and formerly the chair of the CCG, and I'm now the clinical lead for the Hammersmith and Fulham CCG, I suppose. Difficult to know,
okay.
So transition.
Thank you. Good. Sue Rooston. Sue, are you with us? Okay, we'll come back to Sue in a minute. Jim Greeley.
Hello, I'm Jim Greeley from Hammersmith and Fulham, Save Our NHS.
Great, thank you. Christopher Hilton.
Hi there. So I'm Chris Hilton. I'm the recently appointed Executive Director for Local Services in West London Trust, taking over from Sarah Rushton.
Right, well, welcome. Thank you very much. Lovely to see you. Paula.
Hi, I'm Paula, and I'm the Service Manager for Carers Network.
Excellent. Great to see you. Thank you. Glendine Shepherd.
Hi there. I'm Glendine Shepherd. I'm the Assistant Director for Housing Management.
At the Council, yes? Yeah, great, thank you. Carleen
yes,
Duffy.
Sorry.
So, Carleen Duffy, thank you.
Hi everyone, I am the Manager for Healthwatch in Fulham.
Okay, Helen Mangan.
Hi there, hi, I'm Helen Mangan, Deputy Director at West London Trust.
Great, thank you, thanks for coming. Meryl Hammer.
Hi there, Meryl Hammer. I'm Secretary of Hammersmith and Fulham Save Our NHS.
Excellent. Jazz Brown.
Being in from the west of Ireland.
Oh, sorry, being at the west of Ireland, we've got a great connection. But that's, yeah, part of being part of Europe. Part of being part of Europe. Jazz Brown. Jazz, I can see you with us. I don't know if you want. Yeah.
Good evening. Jazz Brown, Chief Exec of Median Life Resource Centre.
Thank you very much. Cheryl Anglin Thompson.
Hello.
Hello. Cheryl, if you just want to introduce yourself.
Cheryl Anglin Thompson, Hammersmith and Fulham Health Partnership Manager.
Nice, good, thank you.
Yeah.
Okay, Luke Santurai.
Oh, good evening. So it's Detective Inspector Luxon Thray-Brunsingham. I'm with Central West. I'm the Detective Inspector for Public Protection's Partnership Hub.
Yeah, and look, I have to apologise. Your name's come up abbreviated. That's why I said Thurai, but it's Thurai Atnasingham.
Right, Atnasingham, yes.
Yeah.
It's because our secure computers can't access Zoom, so I've had to call in from my mobile.
Oh, right. Okay. Well, look, thanks very much for making the time to join us. It's great. Nadia Taylor.
Hello everybody, I'm the chair of the local committee for Healthwatch in Hammersmith and Fulham, and also chair Carers Network, so I'm delighted to see Paola with us, our service manager.
Excellent, excellent. And Kate Sargent?
Kate Sargent, Alzheimer's Society Local Services Manager.
That's brilliant. And we've also got Bathsheba Moore, who's clerking the committee here, who's there as H&F Governance. Sue, you're back. Hello. Would you like to introduce yourself?
Yeah, hi, sorry. I did sort of hear you, but I couldn't respond. So my name's Sue Rooston. I'm the Borough Director for Hammersmith and Fulham, and I had a very dodgy connection. So hopefully I changed device. So I should be all right now.
You're running what's the CCG or whatever the CCG
is? Part of North West London CCG, yes.
Yes. I think that's everybody who's with us. Have I missed anybody out? My apologies if I have. Oh, yes, hello.
Hi.
Introduce yourself, please.
Hi, I'm Peggy Coles. I'm the coordinator of the Hammersmith and Fulham Dementia Action Alliance.
Fabulous. Thank you very much, Peggy, for being with us. I'm sorry, you know what? I've got a teeny weeny Peggy, and I can't see you properly, and your hair's changed colour again, if I may be so bold. If it had been purple, I'd have known I'd have known it was you at a distance. Good. Well, look, thank you all so much for coming. We've got a few people who can't come. I've had apologies from Larry Culhane, Cabinet Member for Children's Services, and Jackie McShannon, Director of Children's Services, Stuart Downey, who's the chair of the fantastic Dementia Action Alliance, which Peggy and Kate have mentioned, and Philippa Johnson, who's Director of Operations at CLCH, and she co-chairs the Integrated Care Partnership with Lisa Redfern from the Council. These people have given us apologies. From Imperial College, Toby Hyde, was Director of Strategy, was with us, but he's on secondment to NHS England, so that's good. And well-deserved secondment, although what do we do to lose him? Imperial hasn't sent anyone tonight, but I've spoken to Linda Jackson, and she's promised to chase them up and get them to nominate somebody else to have the pleasure of sharing their thoughts and sharing our conversations in the future. So can I ask anybody if they have, at this point, which we ask you if you'd like to declare any interest, as opposed to being, yes, I'm very interested in this, any sort of pecuniary or other interest in the item we're going to be discussing? Take that as a no. We've got some, as I said, some people are members, some people are observers, but we of the board, there'll be a couple of points in which we ask the board to maybe endorse or recommend things. If it just be those people who are actually on the board who stick their hands up or something or indicate, that would be appreciated. But it's usually very amiable and comradely meeting, so I don't think that's going to be problematical. So we've got the minutes of the meeting that we had our last meeting. That was on the 29th of June, and you've had the minutes. I'm just wondering are you happy to approve them as an accurate record? Would anyone like to make any corrections? Excellent. Okay, I'll be happy to sign that then, Bathsheba. And we should note the outstanding actions, a number of which are going to come up again because they're rolling themes, and of course dementia is a large part of the meeting today. Now you've got the agenda in front of you, and the agenda we'll be talking about, the agenda as it stands, everything on it I hope we can cover. COVID, Integrated Care Partnership update, the flu vaccination and the COVID booster update, and the draft dementia strategy. Without wanting to bounce this on anybody, I wonder if we could begin with the dementia strategy, unless those who are going to present would like more time to collect themselves, because I think this is such an important issue. Everything that I've just mentioned is an important issue, but I think it's kind of refreshing in a way to start with something which in these times isn't COVID. We must talk about COVID, and there's some really important issues that we have to discuss and cover the ground on. But dementia, there's been some amazing work going on. It's a really, if you're happy for me to move that as the first item. Yep, and those who are going to be presenting are happy, good. Okay, well, I'll do that. So to introduce that item, I mean, this is not a political meeting, but we have a commitment as a manifesto commitment as an administration to make this, to really develop a dementia-friendly community, to make this a borough that supports people with dementia and their carers and their families in a much more active way. We had a fantastic discussion at the last Health and Wellbeing Board about the way that the NHS, the Council, and lots of others are working together. And we have the really amazing good fortune in this borough to have some extraordinary residents who are prepared to throw their back and their life and soul, their body and soul, into working with us to try and improve things for residents. And Peggy Coles, who you just met, is one of those. Stuart, who can't be with us tonight, is another. And they have been absolutely tireless in working with the council, drawing us in, and the NHS and others and others. And Kate, you're here with us tonight, and I'm very grateful that you are, in working really hard on coming up with what they hope will be we will accept, we will support, we will recommend the basis of a dementia strategy for the borough. And by the borough, I don't mean the council, I mean the whole borough and all the players in it. So I really would love to, I'd like to thank the Dementia Strategy Task and Finish Group, I think called themselves, for what they've done. And we're going to be asked, I'm going to ask them to present in just a sec. After that, I'd just like to think we're going to be asking you, the board, if you'd be happy to endorse it, this co-produced strategy, and be happy to support the proposed establishment of Dementia Partnership Board. I'll come back to that at the end. But for now, I'd like to, if we could, have a bit of discussion about the strategy, which I hope you've enjoyed reading. I've certainly gone through, enjoyed it a great deal, and it's been a tremendous experience to have had the opportunity to do that and to discuss it with everyone involved. Joe, would you just like to tell me how you think the best way to discuss it would be best? I've got some suggestions here. Lisa, you could introduce, and Joe, and then Peggy. Or Joe, how have you thought about how you and Peggy would like to do that?
I think it would be really helpful, Councillor Coleman, if Lisa started, and then Peggy and I are going to come in afterwards and just frame some of the areas that we thought the Health and Wellbeing Board would be particularly interested in.
Good. Okay. And I know that, Lisa, I know that you discussed this yesterday as the co-chair of the Integrated Care Partnership. I know that you discussed this yesterday. If you're going to talk about the interest and support from the ICP, do you think we would be best doing that now or after we've had the presentation?
Probably after the presentation, I think it would make sense to do that. I think
we can have a good conversation. Okay. Well, Joe, if you just want to, really, I'm going to, I think you and Peggy now. It's your act. Why don't you? I know that Joe, this is. I just want to say for everybody who's very understands the council's role in this, the NHS's role in the production of this piece of work. We supported it, but it's not our piece of work. It's the resident groups, it's the residents and the representative groups and the Alzheimer's Society and others who you see named in the strategy. And I know Joe and Peggy will talk about that. So Joe has been very active in supporting this piece of work, and as has the NHS. But it is, and I really appreciate that. But it is very much a piece of work produced by the community, and a recommendation to us who can actually affect some change. So can I ask you to tell us a bit more about it, present it, and we'll have a conversation.
Okay, Councillor Coleman, thank you. So I think everyone has the papers in front of them. Just to say, in terms of the Dementia Strategy Task and Finish Group, that Paula and Jazz and Kate, as well as Peggy, are represented here tonight from the Task and Finish Group. So I just wanted to say a particularly huge thank you to them, because we wouldn't be here today if it wasn't for them. So we first came together as a group of colleagues in the eye of the storm of COVID. And initially it was to look at how we could best support our residents with dementia and their families and carers in the context of COVID. And in coming together and with significant energy from Peggy and other colleagues that are on this call, we had the discussion about not just COVID, but our absence of a dementia strategy as a borough. And some of you may know that have been around longer than me in the borough that we did have the bones of a strategy some time ago, but for whatever reason it was never pushed through and trailblazed through the council. And so we felt as a group of colleagues that it would be wonderful to have a dementia strategy, in part because we are committed to becoming a dementia-friendly community as a borough with all our stakeholders, and we've made great inroads in that. We've got over 700 dementia friends in the authority. but also because we recognised there were some gaps in local services and support, some gaps in information and advice, some gaps in how we joined up our excellent work on the ground, and for that reason, we came together and started to develop the strategy, and it feels like a lifetime ago now. It's over 16 months ago. Peggy and I, people on the call have all aged visibly since then, but we've had some fantastic times, some fantastic conversations, and some very difficult conversations with people on the call and with others as well. We began our work by, as one always does, in looking at our data, our evidence base, and you have within your packs our data pack, and we'll say a little bit more about that later. There were some gaps in our data. It really highlighted how much we need to do in collaborating to make sure that we have a really strong evidence base and really accurate data. And then we also did the much more critical bit for everyone on the call, I think, is we developed a number of surveys to reach out at a particularly difficult time in the context of COVID, when no face-to-face work at all, but to have conversations, because all good things start with a conversation with people who live with dementia and their carers and their families, the excellent stakeholders that support them, across the voluntary community, public and private sectors, some of our local businesses. And we brought together that work, and I particularly remember a session with Paula and Peggy where we tried to extricate all the detail from the surveys to give a really accurate reflection of what they told us. And we also undertook a map and gap. Peggy and I were just talking about it earlier. It wasn't the most sophisticated map and gap, but for those of us on the call that have been involved in lots of map and gaps, it was important to start somewhere and get a really good sense of what's happening on the ground. So what you have in your packs, colleagues, is the products of all of that work over 16 months. The surveys, the data pack, the discussions, the conversations with stakeholders, and the recommendations that came out of the work of the data and the surveys. And I think the critical bit for us, and the real exciting and amazing opportunity today, which is World Alzheimer's Day, it just feels that was just an added bonus that we come together on such an important day for dementia and Alzheimer's, is that we have a real opportunity with the integrated care system and the local partnership, ably chaired by our own Lisa and Philippa, to really get the traction and the governance around taking forward the recommendations in the strategy and making massive difference for people's lives at a local level. And I think the last thing I would say is that key to this strategy, as Councillor Coleman said, is the co-production. And, when I first met Peggy, we spoke about the Disabled People's Commission, which we're immensely proud of in the borough. In 2018, Nothing About Us Without Us is such a fantastic principle to have in everything that we do in our work. And I think going forward, as we establish our governance for the Dementia Partnership Board, as critical to that group, that board, will be thinking through how from the onset that we involve and continue to involve people living with dementia, their carers and families, which we're very excited about as well, particularly as COVID has eased and we're able to do, albeit tentatively, more face-to-face work. So I think I'll pause. I think I've said enough. Peggy, I don't know if you'd like to add anything at this stage.
I wanted to focus your mind for a few minutes about the importance of data. And I've been on a couple of calls and I've heard Jim's contribution about the importance of driving things from accurate data. And given the diversification that we have in Hammersmith and Fulham, I'm even more convinced that the efforts we put into data gathering, data analysis, and actual solving around the data is the best idea. So the first bit of data that will draw people's attention will be the dementia diagnosis rate. We unfortunately have the second lowest rate in Greater London. And that number is 57.6%. To give you a bit of flavor for a couple of our neighbors, Hounslow has 65%. So we're again 57 versus 65, and Ealing is up at 68.7. Now, this is a circular story. Diagnoses happen based on people coming forward. How do people come forward? What is the environment in which they live for people to come forward? Right now, we have the second lowest number of people with a recorded diagnosis, an actual piece of paper that says, I have dementia, in Greater London. But we also have the second lowest diagnosis rate. So the expected number for Hammersmith and Fulham, based on historical analysis done by LSE and the Alzheimer's Dementia UK, the research arm of the Alzheimer's Network, are suggesting that we have over 1,336 or 37 people with dementia. And again, just to remember, that's just the person with the diagnosis. It doesn't talk about the carers and the family. So one of the big focal points is to improve that diagnosis rate story. And it is multidimensional, there's no question. And then the other point about data is very exciting, and it starts, in my opinion, with looking at public health and the messaging that we can use in terms of prevention. Dementia is linked to risk factors, and there are increasingly understood steps that people can take to actually reduce their chance of getting dementia. So that's a big area of work for us. And what's exciting about it is that in going about doing the public health education work, it is side by side with the dementia awareness work, which is even more side by side with the growing of the dementia-friendly community. So as we increase the conversations, we increase the questions that our residents ask, and we kind of create a pride and a willingness to chip in, and a positivity around dementia that it might not have, particularly post-COVID. So our risk factors, we're looking at all those things that you would think of are brain health. So what's good for your heart is good for your brain. But one of the things that we are looking at is making sure that all of our recording of how healthy Hammersmith and Fulham actually is accurate. And we have a bit of a challenge right now. And that challenge is caused by one of our GPs is Babylon Health, GP at Hand, a telehealth company. And their patient register includes many patients who live out.
sorry, I'm Joe. I think you've gone silent. Peggy, we can't hear you. Oh, that's great.
Sorry, we were muted then by the host by mistake, I think.
So what's important is that we really hone into accurate data for how healthy are our residents, and we're looking really at over 50, and then again at over 65. So from a data point of view, those are the two topics.
Well, thank you very much. I mean, that's a very good introduction. I mean, if I can just add a couple of things. First of all, I should have made it clear that when we have Newbie Live here and Jazz they've been on this group and part of producing it, but Paula here from Carers Network, and of course I've already said from the Alzheimer's Society and Kate are here, but I'm grateful that you're all here with this in mind. I should have made that clear at the beginning. Can I just take a second just to run through, if you wouldn't mind me re-rehearsing all the recommendations, because they are so good and they are so important. I mean, you talk about diagnosis, and we should come back to the early and accurate diagnosis, which for me is one of the things that most jumped out in the report. Then you've got the need for clear and accessible information about getting services and support, about how we have to treat people with dignity and respect who have dementia and offer them opportunities for good quality of life, how we have to have a good availability and choice of things like day services and short breaks and overnight respite to support people. And when I say people, I mean people with dementia and their families and carers. How the nirvana of multidisciplinary coordination between services, which is definitely here something that we need to aim to, is something we aim in every area, but is challenging. And continuation support throughout their lives, including end-of-life care for people with dementia and their families, and trying to ensure that services meet real needs as opposed to assumed needs, and that means listening to people. Then you recommend having a network of creating a network of peer-led support groups for people who've been recently diagnosed, for families and carers, and people living with dementia, and people who have been carers who are living with bereavement. And you argue for a range of dementia-specific and dementia-inclusive activities, give choice and control, and reduce social isolation, which can be such a big issue, and promote equality. Ensure that the social care and health workforce meets core competencies around dementia, and that's again about training, and that family carers get training to meet their needs, and of course not least that Hammersmith and Fulham as a whole becomes a dementia-friendly community. And those were the priorities, the conversations you had set. And then you've got some specific recommendations that we established a dementia partnership board, and I'm going to ask you to say a little bit more about what that might mean. And I mean, I can read to this, and we can all see it's on page 10 in the document. But the crucial, am I right? Your crucial recommendation to achieve all these things is that we have a partnership board. It has representation from the NHS, the Council, the voluntary and community sector, and people with dementia and their carers and their families. And then it co-produces services for people in all communities, including Black communities and Asian minority ethnic communities. And one of the big focuses is on improving the diagnosis rate, which Peggy, you've spoken so well about. And that we also started, the group board also establishes a data working group and a communications plan. And it keeps all the partners who are delivering this, which is mostly going to be the Council and the NHS, on their toes. Have I left anything out there? Those are the main points of the recommendations, aren't they?
No, they're spot on. They're absolutely spot on, Councillor. And I think the Task and Finish group made sure that we had a really good mix of recommendations, some of which were low-hanging fruit that we could get to straight away to demonstrate to residents that it was worth waiting for, the strategy, and others will take a little bit longer. They're longer term issues and they're complex and need unpicking. Yeah. Very good. And I mean, is there, I'd like to ask, Jazz and Kate and Paula, if there's anything they'd like to add as people who are actually on the group that produced the recommendations here. Jazz, if perhaps I could ask you, it touches on the recommendations touch on the need for support for people from all communities, including Black and Asian minority ethnic, in order to tackle systemic barriers. Can you give us a little bit more of an insight into what you perceive as might be systemic barriers for Black people in getting dementia diagnosis?
I think there are a couple of areas. There's the stigma around mental health. There's the overall understanding of what dementia is. And I think there's just a lack of community resources where people can go along to places of where they feel safe to get that information.
And do you think that's a problem for everybody, no matter their background? Is it a particular problem if you come from Black Caribbean, Black African background or other ethnic backgrounds?
I think the access to trusted places where people can get advice and information and support, and then also the support to follow through in terms of getting a diagnosis and then being able to access services. A few years back, we used to work with the memory clinic, and we used to have community outreach clinics where Dr. Foley would talk about dementia and explain what it was. And we had a real success rate with that, with people actually self-referring. But after the initial contact, they would, maybe get the diagnosis, but not want to go down the clinical route.
And that stopped?
I think it's still the case. And I think when you start looking at,
the outreach from the memory clinic, that stopped?
Yes, that stopped.
Right. And that's maybe something that I don't know who the person from the NHS is most, who's most responsible for the memory clinic? Where I go, James. That's something maybe to take up.
So I'm not responsible for the memory clinic. I wanted to make a couple of points and maybe ask a couple of questions.
Without losing that one, then I'll bring you in definitely. Without losing that, I just wonder if there's anyone here from the Older People's Mental Health Service Clinic. Is that you, Christopher? That is you, yeah.
Latterly, Councillor Coleman, yes. So the older persons mental health services provided by West London Trust now fall into under my remit, and we have a service line within the trust called For Older Persons Mental Health, which incorporates our dementia services across Hammersmith and Fulham, but also Hounslow and Ealing. And I guess I certainly will pick up that question around what happened to the outreach work that's described, because it sounds very valuable and also very consistent with what we would be hoping to do as a trust. But I guess I suppose while I have the floor, would just welcome the report of Joe and I have discussed it and have made links, I think, so some early links with other colleagues on the call to continue the conversation. And I definitely think that the approach that's being taken to develop a group specifically focused on this population is really welcome, and the trust would very much like to be part of it. Hammersmith's an amazing place to work on services for this population, not least because we have the expertise in Imperial around all of the neurology pathways, but also the mental health and community services expertise through our trust. And we've got some examples of the work that we've been trying to do around frailty through, for instance, our community independence service, also to improve the dementia-friendly care that we provide. So really welcome the report and look forward to further conversations on that front, but welcome the recommendations. Thank you.
Thank you, Chris. Thank you very much. I appreciate that. I appreciate the offer to take things up with Jazz at Nubian Life, but also general support for this, and the fact that you think we're well placed to deliver it is cheering. And I'd like to bring James in, but first of all, just as I said, I just want to see if Paula, you'd like to add anything from the perspective of carers to what's been said by your colleagues on the group.
Yeah, sure. No, well, what I can say is that from this group, I think we learned a lot about each other and how we work and the services we provide. And I think it was a very good moment also to identify what we weren't providing and the lack of services in certain areas. And yeah, and I really think that in the future, working together and coordinating is gonna be very good, just to meet all the needs, not just for the people with dementia, but also for the carers. Because as you said before, for example, respite or external support is very, very important.
Yeah, that's absolutely. Well, thank you for that and for participating in it. And I'm also just going, as I said, going to ask Kate if she'd like to add anything. And then I see, as I said, James got hand up and Luxanne and then Jim. But Kate.
Well, yeah, I just agree with what everybody's already been talking about. It's about the partnership working. And I think the way that health and social care are finding ways to work together and all the partner agencies is absolutely what we need and what we want. And I really agree with what Jazz said about addressing stigma and just getting the right approach in various communities and actually being approachable is going to be really important.
Well, thank you. And today is World Alzheimer's Day, isn't it?
It is.
So it is. And Peggy, you were there in Westfield with a fantastic stand, encouraging people to come Dementia Friends. I hope that was successful. I can't imagine you let many people go past without signing them up. That's brilliant. James, you want to come in?
Yes, I think the first thing to say is this is a very welcome initiative. I think everybody who's involved in care of people with dementia and they're working with their families. We've tried several different times over the last 15 years really to increase the prevalence of dementia diagnosis through various different methods, and we still struggle with it. And I think it is partially the stigma, but it's also partially a lack of an effective proactive outreach, not just by health, but also by other partners within the ICP. And I'm hoping that one of the things that the ICP will help us do is start to be more effective about targeting these hard to reach groups, not just in dementia, but in other things. Just a couple of things about the report, well, just one thing in principle. The way you've described the prevalence rate reads as rate of diagnosis per year rather than total diagnoses. And that's a misunderstanding. And I think if you're going to pass this around, I'm happy to, outside this meeting, just correct that. The rate of diagnosis is the total number, not rate per year. And it just looks a bit odd when you read the report through. So it would be useful to correct that. And the question I want to ask the people on the meeting is, you have this dementia strategy, and my understanding, and I'd be happy for the provider to talk to me about this, is that the cognitive impairment group, the SID service, are currently involved in reflecting or redesign of their service. And I was wondering if the people who are involved in the dementia strategy and the people involved in the dementia campaign or the frailty campaign within the ICP are engaged at a sufficiently senior level within that process to ensure that their voice is heard loudly by the chief provider of dementia services, which is West London Trust. Because my worry is that redesign happens and you don't have sufficiently high representation from your group, from the dementia campaign group within the ICP, we're going to wind up with a disjointed service that doesn't focus on the needs of the other groups within the borough that are trying to crack this nut.
Yeah.
And I would love to have reassurance that the right people are going to be at the right level in the right discussions at the right time when SIDS is redesigning itself.
That's brilliant. That's a really helpful point. I just pick up on those 2 points. That's really, thank you for that. I can see Joe nodding along and a bit, Peggy nodding along to your invitation to get the wording right about prevalence. So we'll take that before the final report is issued. And I'm going to ask in a minute, I'm going to ask Lisa to say something about the ICP, and I think she'd want to come back on your point about SIDS and the West London Trust, because I think that's making sure that it's not just words on a paper or words in a document, but actually that the right people are involved in making this change is essential. So thank you for that. And I'll ask Lisa to come back on in just a tick, and then maybe we can get other people to come on it. But I'll just take a couple of other points first. Luxanne, you've got your hand up.
Oh, yep. Thank you, sir. So I think the topic is somewhat, it's a passion close to my heart, as I was dementia trained by the Alzheimer's Trust and, the Alzheimer's Society, and I've been working with some charity work outside of work for the last couple of years, especially with, vulnerable elderly individuals that are particularly isolated in the community. I think it's very easy to sort of stigmatize dementia by labeling it as a disease and, labeling individuals with it. Dementia exists on a varying, on the varying stage of the spectrum. So there's different levels of it. The difficulty is that dementia, often the symptoms of it gets labeled very closely to what you experience in the stages of old age. So a lot of the time it's overlooked, and the risk remains in that there's a lot of individuals within the community that aren't visible to us that have dementia. And I suppose, statistics, it's an indication, but it won't capture the everything in its entirety. So I think there's progressive work to continue to try to identify those individuals. From the police's perspective, the risk is, and from what we've seen, is from sort of people with dementia going missing from their homes. A lot of them tend to live on their own, and then they get reported a few days later having sort of left their address, not knowing where they are, with nothing on their person. And I think the problem that we're experiencing is, how are we able to effectively address this, effectively identify these individuals, come up with a care plan to put into place around how we're going to support these individuals the best that we can to ensure that, within that stage of your life, you want freedom to an extent, and it's trying to approach it with a balanced approach. And I think we will have to sort of continue to identify those individuals within our community from a multi-agency approach, share that information with our NHS partners, and ensure that we're able to put into place an effective care plan for those individuals. I think there's also a need for dementia awareness with the public because it's not easily identifiable, and there's also a need for sort of community engagement with those isolated individuals on a long-term basis. I know that sporadically we'll do activities, but those lonely people do actually need that sort of community contact. And I know it's coming up to the Christmas period, so that's what the festive period is really about. But I think from my experience, from working with people within that firsthand, and from an operational perspective, that's essentially what we've seen. Yeah,
that's really helpful. Thank you. And I mean, I think what I've got there is someone who might be volunteering for the police to be on the Dementia Partnership Board.
I would love to, yeah. Absolutely.
Which is fantastic, and thank you for that. That's really, you make very good points, and which echo some of the points made in the report, and that's very much, I think people respond well to that, and thank you for that. Jim, you wanted to come in?
Yes, first of all, I'd very much like to welcome the report, and I'd like to commend the people who put it together and wrote it, because it's got one notable feature, and its tone is right. It's empathetic, it recognizes the problem, it doesn't use jargon, and does not talk down. And that's actually very unusual in my experience within the National Health Service. So on that level alone, I would commend it. Second, I like the inclusivity of it. It matches our borough with the different populations, different ages and so forth, in a way which many things, including stuff perhaps this evening and other reports, does not manage to do. And I think that's welcome. Now, the third thing is, I like the clarity in the way it outlined a strategy to tackle problems. And again, that's quite important, because without a strategy, what we're doing is we're saying there's a problem, it's a real problem, we think about it, but we haven't got a strategy. There's a strategy here, not finished, but it's well on the way. A couple of things I'd like to ask. One is, I am concerned about the gap in diagnosis in our borough. That surely cannot just be Babylon GP at hand, which recruits patients from right across London. If it is, we'd like to quantify it, but I think it's quite important to work out why is the gap between the diagnosis in our borough as against neighbouring boroughs whose population is not that dissimilar. A couple of observations, I think, as the report goes forward. James Kavanagh is very right. We're working in an ICP, but the ICP itself is part of an ICS, and the ICS is the one which will control the purse strings. And that really is important, that in pushing our recommendations forward, we need to be in with the people who make decisions very early with the report which will lead finance. And when I say that, some of the figures are actually quite interesting. By the end of this decade, there will be a 42% increase of those with serious dementia, not just with the incipient beginning symptoms, but serious dementia. That will mean people with who may need full-time care, will need professional care. In the actual, our part of West London, not just our borough, but neighbouring K&C, there are an enormous number of people who live in isolation, i.e. they've got no families. So they can't call on traditional and now declining family networks across London. So there actually will be a question there about staffing and about paying. And I think it's as well that this was at least mentioned early on. And that seems to me to bring to one more point, and that I think to work well, and there's all the signs that people, Peggy, Joe, etc., you've actually put your hands on the key problems, is that I think it needs to be integrated with an ICS or ICP palliative and end-of-life care. And that is very important because we haven't got one at the moment. And despite COVID, the large number of deaths across the whole country, but our part of Northwest London, we actually need to integrate this into a palliative end-of-life care. One final thing, reading through the report, it's strongest, I think, on council work, on social care, on the social dimensions of dementia. I think there's room for much more about the medical part. And I say that because, of course, dementia is both social and psychological. It affects communities, but at its core, it's medical. It's a medical problem for which there is no cure, as the report very helpfully says. So I would welcome much more on the interface between the social aspect and what the NHS does, both at trust level and at GP level. And when we say the GP is at the front door, a good phrase actually, and we want a different kind of GP service, I would like to see some teasing out of that, because it implies a change in ways people behave.
So a lot of good points there, and I think we're coming towards Lisa Redfern, because a lot of these things are about how the health and care system come together to answer the questions, to try and resolve some of these issues about diagnosis, about data, about all the things that you've raised, Jim, and others have raised. So Lisa, I wonder if I could ask you to give us, as I say, just for those who don't know, you co-chair the Integrated Care Partnership, which is the borough-based partnership between the NHS and the council and others, and is part of the there are 8 ICPs in Northwest London, 8 Integrated Care Partnerships as part of the Northwest London Integrated Care System, the ICS. And the system sets big policy goals and money, as you say, Jim, helps dole out the money. And the ICP also sets its own policies alongside that and talks about how to deliver. So I wonder if you could, and I gather that you had the pleasure at your board last night of having this. By the way, your camera is so that we just about seeing your face, which is
I know. I'm having a few. Is that better? I'm having a few technical difficulties this evening, so I've been on about 3 devices. So do apologise, everyone.
No. That's cool. Why don't you tell us something about you discussed at the board yesterday and about how the ICP wants to get engaged with making this a reality.
Yeah, I think first of all, I just want to say, both on behalf of the council, but also the ICP board, really excited piece of work. I think it was wholeheartedly approved at yesterday's board, and the ICP really want to help to take it forward. And I think that's important for a whole range of the reasons you said, Councillor Coleman, but also a number of other people, a number of other voices around the table this evening, that we need. It's a whole system. We need, to make the improvements that we need to make in Hammersmith and Fulham for people who have dementia and their carers. We've got quite a bit of work to do. We've got to have a joined up system. We've got to have better diagnostics. and we've got to have support and support services that help people not only with dementia but their carers. So that takes quite a bit of resource. It takes quite a bit of money. And it also takes collective kind of brain power, I think, to make that a holistic way of working with people with dementia and their carers. So I think the role of the ICP is going to be quite critical in helping pull all of that together. I think it's a model for how the ICP want to work with residents and with patients, to endorse that co-production as a way of engaging with people. And I think Jim said this, and forgive me if I've got this wrong, but I think the tone is really spot on, and I think that was certainly the view of Philippa, and also the language as well. Very accessible, very plain language, and we'd like everything to be set out that way, and the way the recommendations are set out is really, again, Philippa and I, as with the exec, were just saying that would be really good for the other campaign work and other pieces of work to work in that way.
That's brilliant. I wonder if sorry, I just wanted to see if you'd like to stress the point about West London Trust and the work that they're doing and how that might dovetail into what the ICPs.
Yeah, I mean, Helen Mangum's on the call as well, and Helen's part of our executive, and we need to make sure that the work does weave together, that there's no duplication, and that the right hand knows what the left hand's doing, and that's the whole part of working with the integrated care partnership. So no organisation works in isolation about any aspect of dementia.
Helen, that's very helpful. Would you like to add something to that? It's a good point to perhaps bring you in.
Yeah, I mean, maybe just to say that in the frailty group, my understanding is one of our clinical directors is a key member of that group and supporting that work. And I think we've had some early discussions around the dementia strategy, most directly linking in with the frailty group. So personally, I feel quite confident that we can plug in the right people and get the right discussions going. And my experience of the summer has been that the ICP has really allowed us to do that, the building relationships, the making the connections with the different parts of the system. So personally, I feel quite comfortable. I don't know if Chris wants to add anything to that as well.
I would hope to add to Helen's assurance and the comments that Lisa has made about the Trust's commitment to getting the right people into the right meetings, and certainly I'm looking forward to my conversations with Peggy and Joe and colleagues as I get settled into my job. I wonder if it's worth also adding to a point that Jim made. The integrated care system across Northwest London has dementia diagnosis is monitoring that very visibly, and there is additional investment coming from the spending review and through the long-term plan towards older persons mental health services. So actually having this strategy now will help to guide how that translates into services in Hammersmith and Fulham for local residents. And I know that the Trust is expecting to work with Lisa and the ICP colleagues and the local community about what that means in terms of improving both the dementia services and the overlapping older persons mental health pathway locally.
Brilliant. So that's really helpful, Chris and Helen. Thank you for that. I mean, it's very. The Health and Wellbeing Board has a fantastic opportunity to bring everyone together, but we aren't here all together every day. And so the fact that you're going to get together outside here, but is that just to clarify that we're going to have one strand of work which different people will be involved in at different times, but if there is it wouldn't make sense, would it, to have West London Trust, and I think you're saying it doesn't to you make sense, to have West London Trust doing one thing and a different strand of work which the ICP would be doing, or the Dementia Partnership Board. The commitment is from now on to bring everything together in as it were in one place, whether it's a virtual place or is to bring everything together. And so we will need to, when we've adopted this, we'll need to take forward the formation of the Dementia Partnership Board, but presumably that would also include the West London Trust along with others. That's great. I think this is so just in itself, when we talk about integration, we've already achieving some integration through the commitments made here, which is going to be tremendously helpful in getting better services. I would like to bring this to a close. Meryl, I see you've got a hand up. Is it a little teeny weeny point?
I'll try and make it brief. Yeah, it's as soon as the discussion moved off the dementia thing, it seemed to me that it started to get a top-down, we, the institutions, will get together, and we lost what to me was the strength of this dementia plan, which is that it was bottom-up. It was people with dementia, their carers, the whole social thing from the bottom up, pushing for what was needed, as opposed to the providers getting together saying, oh yes, this is what we need to do.
Yeah.
I'm very worried, particularly having read the other papers, that the dementia strategy is just going to stand out as what we need, and it's not going to be done elsewhere.
Okay, let's take that point, and then, because I think it's an important point. It's an important point to raise. The crucial point I see in the report, which is meant to ensure that isn't the case. So let's spend a second on that. Is that this would be driven and guided by a board, the Dementia Partnership Board, which would include, besides the providers, as you call them, or residents and businesses as well, because they're part of the local community. And I just wonder if we can have a little bit more understanding of how those residents and people who are not from the NHS, the council, and or indeed would actually have the opportunity to be on the board, how they'd be selected and how they'd be representative, and how that's like to be taken forward. Who would like to, would it be Peggy or Joe, or who'd like to speak to that?
Could I maybe come in first?
Yeah, sure.
Thanks, Councillor, and thank you, Meryl, and that's spot on. I think when we first met as a group, we talked about a model that we had in children's services with our SEN, our Special Educational Needs Parent Carer Forum. And some of you will have seen this model before, so don't look cynical until I finish the sentence. But it was called, You Said We Will. And what we did was the organisations that have access to lots of residents, some of whom are represented on this call, Paula and Jazz and Kate and others, they helped us, supported us in organising a range of focus groups. And we organised those focus groups around the areas that were of most interest to residents, not to us as stakeholders, not as officers, but to the residents. And they're the themes, the recommendations of those areas that are most interest to residents. So what we thought we would do is have a number of rolling focus groups with our residents, where, Meryl, as you say, they hold us to account. You said, we did. Regular updates so that it's a live document, not something that you do at the end of the year to showcase a few issues, but some of the granular things, and the low-hanging fruit I spoke about, and some of the bigger things, so people can see that things are starting to change and improve, and they can feel it and see it and touch it in their community.
That's helpful.
I think
on the board itself, and I'm sorry to interrupt you, but on the board itself, are you, because the idea of going out and talking to residents groups is going to be essential, but you wouldn't necessarily need a resident on the board to do that. On the board itself, will you have residents representatives?
Yeah, I think so. Just speaking briefly, and Peggy might want to come in, but we've spoken to Kevin Caulfield and Tara Flood, our co-production leads in the council, about this, and their view is definitely yes from the onset. But we all know that to get people meaningfully involved, we need to give some thought as to how. How can we include people on the board so they're meaningfully involved and not sat there thinking this is the most boring meeting I've ever been to in my life? So I think we need to do some really careful thinking and make it meaningful. But yes, we must include them on the board. That's our view, we must.
So that's brilliant. So this brings us to what we just as a group now just need to decide and agree formally, if that's okay, which is that I get the feeling that we're all happy to endorse the dementia strategy. And that means, when I say endorse it, that means everybody here is prepared to put their back into delivering it. In their organisations, this is the members of the board, into their organisations delivering it. If there's anybody has concerns about whether their organisation might be involved, let us know now. Otherwise, are we happy to endorse this as a health and wellbeing board? Yeah. Okay, I'll accept. I'll say silence has been golden there as a yes. It's difficult in the same way. And the proposal, and this is where the co-production angle comes in. But the way I understand the report is that there would be dementia, as we've just touched on, the Dementia Partnership Board, and that would have on it the NHS, the council, the voluntary sector, residents, and businesses, and that would oversee the implementation. It wouldn't be operational, but it would oversee the implementation of the strategy, which would be, and that would represent, it would have people from the ICP, so it would be aligned to the work of the ICP, talking about providers, yes, but very important, West London Trust, so allied to the work they're doing, and all the others here in the room, the council and residents. We need to find the right way of making sure that they're properly represented and representative. Are we happy to endorse the concept of this being driven by that and buy into, if you were, how do I say it, being overseen by a Dementia Partnership Board? Does anyone see any challenges in that? We'll see this as a useful. That's good. Well, and I would say that I would like to add to that the Health and Wellbeing Board, I'm sure you would like to receive regular reports, and it could be from the Dementia Partnership Board and from others about the progress of this strategy. And the first thing will be how the board is put together, the work program, and all those sorts of things. Yeah. Yes, sorry.
Coleman, can I just quickly come in?
Yes, please.
So whenever we make a decision like this about a certain board overseeing a certain element to deliver, we have to remember what agency they have in relations to actually making decisions about how services are designed and whether or not they're resourced. And at the moment, the governance or that structure isn't clear because the government really hasn't published the final legislation in relation to how ICSs and ICPs will work together. And so absolutely, let's say we would like that to happen, but I'm worried we're giving a board a responsibility they can't deliver on because they don't have the authority to deliver on it.
Well, the authority in the absence, it's an interesting point. And because that's it's an interesting point. Is do you have to have, if you have a dozen organisations from different backgrounds, fewer than a dozen in a room, it seems to me they can each make a commitment on behalf of the organisation they represent, which has its own way of doing things. It has its own budget. It has its own staffing, but they make a commitment to work together with others to achieve something. And that's how I have to say that's how I saw this being. We're not going to be able to say the partnership board has a budget and things. The partnership board is going to be made up of people in the room here today working together to try and achieve the strategy. But it's not. But the ICP, it'd be great if there was funding that comes from, if the individual partners here get extra funding. I mean, people are going to have to become pretty expert. I can see that Joe and Peggy and all the other members of the group that produced this great piece of work have become pretty expert on the vagaries and the arcane way in which the NHS and to an extent the council works and the various bits that they have to be joined up. It's just getting them joined up consistently now, even before we talk about pots of funding, I think is the first stage. So James, I think a lot can happen even while the detail of the ICS is being developed. I don't think that would inhibit, unless anybody else thinks, I don't think inhibit, Chris, you being involved and putting your oomph behind this, would it?
So I absolutely agree with you. Let's be optimistic and let's go forward with that spirit. Absolutely.
Thank you. Okay, the last point I'm going to take is Luxan. Yep.
Yes. So sorry. So just to support you, I think part of it falls under our own statutory function. So if we're just proactively addressing an issue within our sort of statutory function. So just in support of what you were saying. So
great. Yeah, well, that's really helpful. Thank you. Look, it's been a great piece of work to be aware that's been going on. It's been a lovely to hear that from everybody. A lot of conversation, I have to say. It's a good piece of work. Now, of course, I hate to say this to those who've been involved so much and have spent so much time, the real work begins. So good. Thank you. Well, thank you all very much. The council and the NHS Council absolutely behind you. We will carry on giving this process all the support. Come back and regularly to the board. Tell us how you're going. We can and tell us about the challenges and see if we can help address them. Though I think probably you'll have addressed a lot of them by the time it gets here. But I'm very proud that we're doing this as a borough, and I'm very grateful to all of you for what you've done and for what you're going to do. Thank you very much. What I'm going to do is give you 5 minutes for a comfort break, if that's okay, and then we'll come back and talk about the other items on the agenda. Yep. So I'll see you in 5. Thank you very much.
Thank you, Councillor Coleman. Thank you.
Thanks. Hello, Jim. Right, we'll reconvene, I think, in a second when everybody's back with us. We're ready to go. Now I see a lot of I see a lot of not a lot of faces and a lot of people with their mics off, but we're ready to re-begin. If you're there, if you wouldn't mind showing that you're here, that would be great. Thank you. Thanks. Hello, Jackie. Jackie from Children's Services has joined us. That's great. Good. A lot of people. I don't know if Nicola Lang, Linda, you're here. Nikki Lang is going to be presenting with you, talking with you about COVID. I don't know if Nikki's, we'll give another second for her to come back and join us. There you are, Nikki. Thank you very much. Fabulous. Okay, I think we've got enough, excuse me, a little snuffle. We've got enough people with us to make us go on to the next item. Now we've got three things to talk about, and I'd like to sort of give them about 15 minutes each, if that's okay with you. So we're aiming to finish about 8. And the first is the where we are, the borough's ongoing response to the pandemic, and I'm going to ask Linda and Nikki to talk about that. Then Liz is going to talk about, with Sue, about the ICP, how it's developing, progress made to date, which I think we've heard a bit about the ICP, but it'd be good to hear some more concrete discussion about that. And then an update back to Sue and Linda to talk about flu and COVID booster vaccination. So let's kick off by talking about the borough's ongoing response to the pandemic. Linda and Nikki, over to you.
Nikki, do you want to start?
Yeah, thanks, Linda. So our current rate is 203 new cases per 100,000 people in the last 7 days. So our rate is gradually coming down, but it's not coming down to the level that we would like. We're not amongst the highest rates in London, and the picture in Hammersmith and Fulham is consistent with the rest of London. And also, you may have seen in media, is much lower than the rate in the rest of the country. In terms of outbreaks, we have a number of outbreaks in our schools. So you will have seen that our schools have come back, and we have a number of schools outbreaks, which we are managing very, very actively, along with Public Health England. We take a very proactive approach to preventing outbreaks in vulnerable people settings, including schools and schools in which children with special needs have their education. So that's the current update at the moment, and I'll hand over to Linda now.
Thanks, Nikki. Just to say that we saw a slight spike in over 60s, and we're just watching it. It's nothing to be worried about at the moment. We're just watching it. There isn't the impact. Our NHS is not seeing the impact of COVID necessarily on them. There are demands on them, but they're not as a result of COVID. I'm not going to touch on vaccinations and flu because myself and Sue are going to go on to that. The other thing, just to say that the government published their winter plan last week, and I'm pleased to say we were ahead of the game on that. The 3 things that they said we must continue is vaccinations, testing, of which we've remained the highest rate across London consistently since we started, and also looking at contact tracing as well. And we've continued, we've been doing contact tracing for over 12 months. We took it on from the national pilot, and we remain good performance on that. So there's no intention for us to stop doing that. The other thing that just to raise with people is that the government have now written to all our clinically extremely vulnerable residents, and they've now formally from the 1st of November stopped the shielding programme. We have maintained access and contact with people who wish to remain in contact with us throughout the last 18 months. and we have no plans to stop that happening, because you know, COVID will be with us for some time, but it's not so much COVID we're dealing with now, it's the impact that COVID has had on individuals that we're working with. So just to give it some reassurance to members of the public, you may have read it on the news, but at the moment we are maintaining that support, albeit low level, but necessary and essential for people. So I'm going to stop there, Councillor Coleman, if that's okay.
I was just saying thank you. Yes, that's great. Let me take any comments or questions from people first. Anyone like to clarify anything or ask a question? Just, well, I'll kick off with one then. Nikki, you talked about schools, and it's obviously it was widely expected across the country that when schools came back, there would be a new infection breaking out. How well are our schools responding to this, and how well are they? I suppose, putting it cheekily, how much are they listening to what the Director of Public Health is saying?
Yeah, thanks, Councillor Coleman. Our schools are very much working in partnership with us. They know us very well. We often help the school before Public Health England, because their early notification system is just to tell me and the head of infection control, and we sort of jump right on it right away. So we're very proactive. I think some of the challenges are the removal of contact tracing. So what we find is, for children under 18, you may have seen that reported in the media as well. So what we find is our schools in Hammersmith and Fulham are very good. They are, when they have an outbreak, putting in place all the mitigation measures. So they are, you know, restricting people's movements, going back at times to wearing face coverings, and are taking all the steps that they've been asked to do. And it's very seamless, our schools work. So we have very early notification, and schools are very much on board with the mitigation measures that they have to do. There's a Public Health England system called Red, Amber, Green, and they're very much doing that. They're also very appreciative of the help. But as you can imagine, schools, head teachers, they are educators. It's a shame for them that they have to be engaged in, you know, doing, you know, virus prevention. But yeah, they're doing a great job.
Thank you, that's helpful. And Jackie, you wanted to add something there as Director of Children's Services.
Thank you. Yes, just to say that it's a measure of the confidence that schools have in the Children's Education Department and Public Health, that they continue to engage so brilliantly with us and are so responsive. We've maintained the dedicated staff member in order to, so we didn't collapse that role once the measures were rescinded, but we've maintained that so that we do have that early intervention. And Dr. Lang continues to meet with our head teachers. I think you're meeting tomorrow, Nikki, with our secondary head teachers. So we keep those relationships very alive, and we have invested time and resources into those roles, which actually aren't funded by government. So there are expectations government had for us that are unfunded, but we've continued to maintain that high degree of contact.
That's very good to hear. It's depressing that I think, you know, again, the government says we'll meet all costs that local councils encounter as a result of COVID, and things that we're expected to do, which are good things, or things that we think we need to do, aren't always covered. So I think that needs to be borne in mind. Can I just understand, Nikki, if you wouldn't, just when you said the removal of contact tracing, and I should be on top of this, but what did you just say a little bit more about that, what that means and the impact?
Yeah, so the contact tracing rules have changed so that if you're a child under 18, you no longer need to isolate if you have been a close contact of someone with COVID. Obviously, in the days before that amendment came in on August 16th, if you were the close contact of a COVID case, you would have to isolate. But what we're finding, which is really good, and having been on an outbreak call today, our head teachers are so in tune with the nuances of contact tracing. They're often doing some contact tracing themselves, and they are having those very mature and sensible conversations with parents and saying, you may wish to keep your child away. And obviously everyone's getting a PCR test if they've been a close contact. So there's as Jackie said, there's a high level of sophistication that I find in our head teachers and our schools. It's, if you look back from March 2020, they started having to think about things like PPE. The teachers are just really highly attuned professionals, and they're finding their own ways of communicating really complex public health concepts, but making it work for the schools. And that's actually something that's really beautiful to see, actually, looking back at this point in the pandemic, is just having trained educators actually understanding COVID and where it can go up and down, and they're actually doing lovely public health work.
That's fantastic, and that's very, maybe there's something we can build on outside of COVID, you know, which is, it's great. Thank you very much for that, the work you're doing there. Is there any more questions? Anything anyone wants to clarify about the outbreak? I'm going to ask another one then, forgive me, and then that's going to be it. I just want to understand about quarantine hotels, about travellers returning from abroad, what the situation is with that now in the borough, and the sort of support and the quality of the support that we're getting for central government.
Okay.
To Linda,
so we have one mass quarantine hotel in the borough. The mass quarantine hotels are actually run and supported by the Department of Health. So what we are finding is that they are very well organised. They have a contract with the hotel to provide welfare services, so toiletries, nappies, etc. for people. People, obviously, the number of red countries have changed. We have had a number of Afghanistan refugees in our mass quarantine hotels, and they have come from various parts of the country. So the mass quarantine has been run extremely well, and we have had no concerns. We've done our random checks in there, and we've done our own welfare checks, so that's great. The Bridging Hotel, which is a hotel that once people have quarantined, and these are not holiday makers who've quarantined or people coming back from work. The Bridging Hotels are for Afghanistan refugees. We have one in the borough, and that is run by the Home Office. We have taken responsibility for managing the health and well-being of the whole of the individuals in the borough. So that's limited responsibility and role for the Home Office.
Is that because they weren't doing a very good job?
Yeah, basically they didn't do a very good job with the refugees elsewhere and asylum seekers, so we've taken control ourselves, and we've done that really well. You have, that means extra work for the council, and I know you're coordinating all the council's efforts around Afghan refugees as well as around COVID. Linda, is that costing us more money, and are we getting any reimbursement? So it's not just, I have to say, it's not just for the local authority, it's for NHS colleagues as well. There's a lot of work that's happened, and we've worked really hard together and very smartly. We are in the middle nationally negotiating a package, but it's nowhere near recoverable full charges. But the Bridging Hotel is coming together. It's working well. We're getting to know people. We're getting to understand people. And we're just trying to make sure that we keep track that when people are going to be moved on, we're notified of it in advance.
Yeah,
I think Sue may want to come in about health.
Yeah, Sue, would you like to?
Yeah, thank you. So just to add to, obviously, Linda, we've had a health response as well to the Bridging Hotels that has been coordinated across. So we've got 5 across the inner cluster of boroughs that we've got locally, 1 obviously in Hammersmith and Fulham. So we've done a coordinated health response, and we are required to register all of the residents within the Bridging Hotels to local GP practices as permanent registrations, and that process will be undertaken. Well, it started already, and it will be complete hopefully by the end of this week, where we will have the residents of the hotel in Hammersmith and Fulham obviously then registered locally. And we will also be discussing tomorrow on our regular vaccine call about offering COVID vaccinations, and once registered, obviously childhood IMS, etc. So I think it has been a very coordinated response from health and obviously social care, despite the difficulties of getting, the information that we require, that we needed from the Home Office to facilitate that. But I think it's been a good piece of joint work locally.
Well, it's good. It's so important that these people are properly integrated integrated, that they get all the health support, the other support that they need. I know, looking at education and a whole range of things, it's depressing that the Home Office has yet again been so crap. Forgive me, but Linda, really have been quite restrained in some of the detail that you've shared with me in recent weeks. But I'm really so impressed with the work that you're doing in the health, and the NHS and Sue and her team are doing, and the way that we're working together, which we've learned to do so well and better through COVID, is paying off. Nadia, you wanted to add something?
Yes, thank you very much. I don't know whether this is appropriate to ask my question, but I think given that
we'll let you know.
Dr. Nicola Lang, I think it might be. I'm very concerned that face-to-face consultations with GPs are very difficult to obtain. I mean, I'm very fortunate that isn't the case with my GP surgery, but it is the case elsewhere in the borough. And I understand that obviously at the height of the pandemic, the NHS England medical director wrote to GPs recommending telephone or video appointments to avoid patients coming into surgeries, but we are in a much more stable situation now. And to be honest, I'm very much of the opinion that while many patients it is with new technology and like that remote care, this doesn't suit everybody, and many people do not have smartphone or online access. So I wanted just to ask, what guidelines have been given to the surgeries in the borough in terms of seeing patients, and just really wanted to sort of say that virtual care is always going to be second best in my opinion. And in fact, it's very much a compromise. And I hope that it's not going to become the sort of new acceptable form of providing care.
Thank you. Okay, well, that's a good question. Sue and James, I can see, but James, come on. Would you both like to have a stab at that? Thank you.
So, yes, go on, James, you go.
Okay, so first of all, I'd say I'm sorry if you're getting a good experience, but we don't want patients who, let's be honest, pay for the services of general practice to feel they can't get access to them. And I'm a working GP. I spent today working, and I saw lots of people face to face, but all of them were initially triaged through either a telephone call or an e-consult access route. And if you speak to my colleagues, what you'll hear is that, in fact, access or routes of access into primary care have increased, not decreased, through the COVID period, as we've embraced innovations in digital technology, and we've embraced proactive care to reach out to hard to reach groups because of the need to vaccinate them. We're much more aware of our population that we can't or haven't been able to reach before. But we do have to triage patients. We do have to keep them safe. We can't have walk-in waiting rooms full of people potentially spreading COVID. So the directions from the government, the Department of Health, to general practices that we should be triaging patients and seeing people face to face as is appropriate, because there is still a risk from COVID. So I absolutely agree there is a digitally excluded population. We're trying to work out ways of proactively reaching out to them. It's very difficult because a lot of them don't have phones that we would normally access through. But we have to remember COVID is not over. You can still become unwell if you've been double vaccinated.
Right.
And there is a percentage of the population that are not vaccinated. So I absolutely hear what you're saying, but we have a responsibility to protect both the public and our staff.
Well, before I Sue, I'd like to thank you, James. And Sue, I'd like to bring you in, but can I just take a question from Jim or Meryl? We haven't got time to have a question from both, so I'll take a question from Jim because I saw you first, and then Sue, and then we're going to have to move on. Jim, you're on mute.
Sorry about that. Chair. I think what James says is right, is that COVID is not finished. Surgeries are not safe. But I think the problem is a straightforward one. It's one of communication. Is rightly or wrongly, perhaps wrongly, very many of the local public have the impression, because of the way messaging is happening, that they're not welcome in the surgeries. And I know James can tell us that this is not what doctors intend, but that's what's been picked up. And I think it's worthwhile across the GP Federation or wherever of looking at messaging and to explain quite simply that we want to see you safely, we want to keep our medical staff safe, and we know many people will need to come in, particularly as James can say, because I'm not a doctor, he is, that very often you'll actually pick up more serious conditions than the patient feels they've got themselves. But across the topic at the moment, what's the worry is it's the messaging part, and it feels exclusionary. It shouldn't be that. And so it's a matter of looking at how one explains and puts it on all the GP practice dashboards and so forth, so that people actually don't feel locked out.
Thank you. Sue, would you like to come back on all that?
Yeah, it was just, and Jim, I completely agree with what you've said about our communication processes and how that needs to sort of shift and change. We recently had some primary care workshops about sort of tackling winter, because obviously it's coming. And one of the things that we sort of had was a clear action around consistent, clear, simple messaging to get people to the right place, to see the right, to the right service. So I totally concur with that. The other thing that we need to recognise is the infection prevention control, as James alluded to. We can't have large waiting rooms with lots of people in the same way hospitals are still being very careful about how many people attend their outpatient appointments sort of physically and who gets seen virtually. So we're in line and consistent with other healthcare providers, and it really is to manage the COVID situation and prevent the spread.
Okay, I'm afraid, Meryl, I'd like to take you, but I'm afraid we just don't have time for this particular item because we're going to overrun furiously. So I'm going to move on to the next one. Forgive me. Thank you for your questions and the answers. The next thing we're going to talk about is the ICP update, which is I think an issue which everyone wants to hear more about. The ICP, well, we've described it several times in this meeting, so I'm just going to ask Lisa, as I say, Philippa Johnson from CLCH, who's co-chair with you, can't be here today. So you and Sue are going to talk about the ICP, where things are, where they're going.
Okay, thank you, Chair. So I'm absolutely delighted that the ICP's been mentioned quite a few times this evening, because I think that really shows now that the ICP's really up and running and doing quite a bit of serious work and starting to take the health and the work of the health and social care and wider system of the borough forward. I'll assume that everyone's read the paper, and anyway, I know we're pushed for time as always far too much to talk about. But I just thought I'd give a bit of an update, and I think the two broad areas that I want to update on, and Sue, feel free to jump in as well, are the 4 campaign groups, the work streams, and also the work of PPL, the partner that the ICP engaged to help with our development. And those are the two things that I want to talk about. Just to remind people, the ICP has 4 campaign groups: the mental health, health and wellbeing, frailty, and diabetes. And the work of those groups, and update of the detail of the work of those groups in section 5 of tonight's report. And that really gives some idea about the details. I think it's fair to say that the campaign groups are at different stages. I think, for example, the diabetes group that was fairly well evolved even before the ICP came into being. I think they're further forward with some of their work. And I think, but I think most of the groups now are starting to get into the focus and some key deliverables. So hopefully the next time that we give an update, we'll be able to talk about some of that. Sue, I don't know whether you want to come in on any of that, or if I've kind of just done a reasonable roundup of what those campaign groups are doing. I didn't know if you wanted to say anything else about diabetes.
Yeah, no, not necessarily about diabetes, but obviously we've got Helen, who is sort of one of the leads for the mental health group, and obviously that links very much again into sort of some of the dementia work, but also some of the work around integrating teams and sort of linking that sort of into the integration piece, and looking at sort of rehab and sort of reablement in the borough, as well as some of the physical health check work. And the frailty work, again, they're sort of focusing, I think, Joe, you said it earlier, around sort of, mapping and gapping. So they're looking at the mapping of the services and how they interface with sort of partner agencies and services as well, and also looking at data. And I think there was a bit of a at the ICP board yesterday, Lisa, there was a bit of a sort of a eureka moment in the sense that we were considering some of the health and wellbeing campaign and how we might revamp. And we had a really interesting talk from a consultant who specialised in heart failure and some of the prevention piece that we could perhaps do around that as part of our health and wellbeing campaign. So they're evolving all the time, and I think they are, as Lisa said, we're waiting now to sort of try and get some crunchy deliverables that we can start to sort of bring back some real results for.
Okay.
Okay, so we can come back and talk. We can come back and talk about that in a moment, or open that up for discussion. PPL, basically we're engaged to help with the support, to support and develop the partnership, with a particular focus on engagement as well. And I think they've done quite a good job about that. But again, there'll be members of this group that I'll want to comment on that. For example, last week we had a really positive, I thought positive, productive workshop. Over 40 people attended, quite a few members of this board tonight. Chair attended that. And the three themes of the workshop were: how do we deliver tangible impact for our residents? How do we work with our community to create change? And how do we create a shared identity? And I think pretty much people there was a consensus really across the three topics, and key challenges were identified, and we'll be able to feed back in more detail on some of those things as well. In terms of engagement, because I think at the last Health and Wellbeing Board, you were particularly keen, or this board was particularly concerned about engagement. And again, I think that's what PPL, that's been one of their focus points really, to look at how we can improve engagement with the wider community, with wider stakeholders. And section 4.5 of the report talks about key findings of the engagement work so far. And section 12 of the report gives an update from the ICP engagement lead. So there's quite a bit on that. We've heard tonight about the dementia strategy, and I think that's as I said earlier on in this meeting, the dementia strategy is a good blueprint and a good model for how we do need to engage with people. And I think it's given us a real lift and I guess inspiration really to what can be achieved and how we can achieve it as an ICP board. And I think I'll leave it there really. There's lots to go at, but I think at the moment we're certainly getting into, I would say, we're getting into more serious, I guess, work, and the ICP is beginning to, its profile's beginning to build, and we're starting to get a really good idea of what we need to prioritise and where we need to focus. Thank you.
Thank you very much for that. That's helpful. Can I take some questions? Meryl.
Unmute. Just a few things. First of all, it follows on from what I said earlier to some extent. The campaign groups are still being talked about, and I guess that's where it is, and nothing much is going to change about those being the 4 areas. But the work still seems very top-down and very different from the dementia group, which was reported on today. And I really do think that if the ICP is going to be serious about this being more bottom-up, more left to right rather than right to left, as I said in some other meeting at some time, then I think it's time that whole issue is looked at more carefully about how residents and patients are not simply engaged, but are actually part of the process. So I'm just deeply, deeply concerned that the point of that involvement is going to be when too much is already in stone. And that's not how it's happened so productively and so positively with the dementia group. And part of my concern relates to, and I'm sorry, Ben, I'm going to sneak in what I was going to say earlier on the GP issue, is that if you go out and actually ask people in Hammersmith and Fulham what a major concern of theirs is, looking at next door, the emails there, I reckon you're going to get a hell of a lot of them talking about access to GPs. And I think there are a lot of issues around that, one that James Kavanagh did not.
I'm not going to re-rehearse that, though, if you forgive me. I appreciate you've been sneaking it in, and I'd note that, but I want to get an answer to your first question.
I was going, well, can I come on? Because another bit, because I think this is an important point, and maybe the Health and Wellbeing Board can address GPs, because we've also got a shortage of GPs. But the other thing about engagement and involvement of residents and patient groups is will or when will papers from the various board meetings be made accessible, and how will they be made accessible to the public?
Okay. So that's helpful about the papers and about engaging in the co-produced things in the co-produced way. Lisa, do you want to come in on that?
Yeah, I'll come in on the I'll come in on the engagement piece first. So one of the key, in section 4.5 of the report, one of the key findings of PPL is exactly that, Meryl, that in terms of co-production, the ICP needs to build a shared approach to co-production using assets that exist already in Hammersmith and Fulham. And true co-production means working with all residents and communities through planning, delivery and assurance. So I don't think there's any disagreement about that at all. I don't think there is any disagreement in terms of what needs to be done and an acknowledgement that we've got work to do yet.
So if I may just build on that, if you could come back to the next meeting and give us some more detail, if we could focus, because the ICP at the moment is Norman, Foreman and Stormin, and you're getting, it's new. And and for us, we're hearing about everything the ICP is doing every time, which is sensible because we're getting to hand. Yeah. But if we could focus on perhaps at a future meeting, we could focus a bit more on the actual taking the recommendation that PPL's come out with and how the co-production and the work with residents is going to happen. I think that would be very worthwhile. Yeah. I'm not going to expect you to have a full answer tonight. I think what you've done is you've said you're recognizing that as an ICP. Then the next thing is how. What that leads to.
Correct.
Good. And the notes of meetings, I think Meryl touched on.
Yeah, I think I certainly will take that back. I don't know whether Sue wants to come in here. Again, that's completely vital, Meryl. If we are going to work with people, that people have got access to key documents and so on. And I'm sorry if that's not feeling the case at the moment. So we've clearly got some work to do on that.
Good. That's helpful. I mean, I think this is all about Meryl. I mean, I appreciate Hafsan is a very helpful partner in the work that we do, and raising issues like this is really helpful. As I say, the ICP. I was go back a couple of years, very skeptical about the ICS ICP. I see real opportunities now, but I also, partly because of the individuals that we're now working with in the ICP and in the ICS, who seem to have determination to make it work and to listen to comments like yours and improve things. So let's see again. The proof of the pudding, Meryl. We'll see. I want to say something in a minute myself about inequalities, but Jim, why don't you come in?
Very brief indeed, because Lisa has answered much, but not all of what I said. What I was going to ask. One thing I like about the borough, not just it's a listening, learning borough, and the ICP, which is in its infancy at the moment, where we're starting off, but making space, and I like the way it's been done. If in the course of listening, one finds that large groups, significant groups of residents, actually will take all four areas which are prioritized as very good, which in my view they are. But if you find there's another area which is not being talked about, which has been missed out, and which really does have an important social implication, is there a way of actually inflecting what otherwise may seem a too rigid four-part decided before COVID, that you find the residents want to bring in or to reflect something? Is there a way of ensuring that happens. So we're not actually caught with the plan, which we started before the COVID epidemic came and really did change life for us.
Lisa.
Completely, Jim. It's not set in stone, and as I think as we're saying, I mean, we're still hopefully a bit more than norming and storming, but I think nothing's set in stone, and we have to be responsive. We have to be responsive to what's going on. That's part of the listening. So I think that point is a point well made, Jim.
And Sue, thank you, Lisa.
So yes is the answer.
Yeah, and just to follow up, I mean, I think at the last meeting you would have heard Philippa saying around sort of the 4 campaign areas and the 5 priority areas that actually we were going where the energy was at that time. That's not to say that actually other things will bubble through and things will then. So if you think about the discussion we had earlier around dementia, that's come through the ICP board as well yesterday. We've also had good conversations with Jackie and the children's team about how we do something around health and wellbeing for children and young people, and also in the mental health group as well, sort of looking at some of that. So I think there's always opportunities to add to those. What we didn't want to do was end up with 25 priorities and not get anywhere with any of them. So it was about how do we focus and try and build on something that we've already started.
You've got the flexibility to bring other things. Thank you. And Sophie, I'm glad that you're past the storming and norming part, Lisa. You're the forming part then, aren't you? So that's good. But thank you. Good questions. I'm going to move it on, because I know we could take any of these issues and talk about them all night, but then you might not love me or each other as much as you obviously do. So let's move swiftly on after that. I'd like to, with a couple of things on the future work programme, which I'd like to leave a couple of 5 minutes at the end for. But then the next item, so I can see us running a little bit over past 8. We might be able to get 8:15, but I am trying to gallop towards the finish online, if I can bear to have a bit more of your indulgence. We need to talk about the flu. It's billed in the agenda as the flu vaccination update, but actually it's going to be a flu and COVID booster vaccination update. And Linda, that's again you and Sue. Which one of you would like to kick off?
It is, yes. So this is a joint report from both of us, but I'm going to let Sue take the lead.
So thank you, Linda. Thank you. So yeah, again, this is a joint piece of work that has been happening, not least as part of the ICP, but also just across our organisations. You will note that some of the paper appeared to be a little bit vague. That's because it was submitted on Monday evening for publication ahead of this meeting, and then the JCVI obviously issued more guidance on Tuesday. So this bit will sort of hopefully clarify some of the bits that were alluded to in the paper, but not necessarily sort of the full detail around them. So just to let, in terms of the booster programme, we've now had the notification and the... Oh, I got a bit of feedback then. We've had the notification and of delivery schedule of the booster programme. So some people may have already received texts about coming forward to take up the booster programme, and that will be offered to all people in the borough who are 50 and over, or those who have sort of an immunosuppressed or immunocompromised condition. And that will, we've got 4 sites in Hammersmith and Fulham who will be delivering that booster programme. They are Brook Green, Surgery, White City, the Community Centre. We've got the West Kensington Tenants Hall, and we've also got Hammersmith Surgery that will be nominated sort of PCN sites for delivery. So that's really positive. 2 will go live next week, Brook Green and White City, and the other 2 will follow shortly afterwards, because they are just going through their final drawdown of the vaccine and their final stages of assurance, because they are new sites delivering the programme. In addition to that, the other positive news is that we have been fighting quite long and hard for additional pharmacy sites in the borough. We have 4 pharmacy sites currently. That will increase to 11 for the booster programme and the flu programme. Obviously, all pharmacies will probably be delivering flu. And they will go live as part of phase 3, the booster programme as well.
Sorry, Sue, is that 11 or 14? I just got
14. So it's 11,
minutes.
so it includes the 4, so it's 7 additional, so 11 in total.
So we've got 14 in the report and 14 in the map.
My apologies.
Sorry, in an email that came around from Northwest London. I should say, yesterday. Sorry.
So my understanding is that there is 11 in total. So and that would be 7 additional.
Yeah, I think there's been some miscommunication since this report went out and something that's come out from NHSC. So we will, sorry, not NHSC, Northwest London. So we'll come back and confirm that with you, Councillor Coleman.
I mean, if there's more, that's great. But my understanding was it was additional 7. Yeah, we're not going to say no to them.
No, so, we're not.
Shouldn't, no. Okay.
But sorry, can I just add that we've got several just on the edge of Hammersmith and Fulham as well.
So it might be those, that are sort of the cross-border ones.
Right.
We're also starting the programme in care homes. So as you know, we've got 4 care homes locally, so we will be delivering booster programmes to them. And obviously then those patients who are unable to leave the house, CLCH, are working with us to deliver to the housebounds as well. In addition, obviously the JCVI did also recommend a programme for schools. So building on the work that Nikki discussed earlier, obviously from a public health perspective and a school nurses and nursing teams perspective, going into schools to also deliver the vaccination programme to the 12 to 15-year-olds. The national protocol and the patient group directive, which is the sort of guidance that allows the prescribing and the delivery of the vaccination programme, was also issued this week. So there's been a lot happened since the paper was submitted and obviously now. The key things to remember is you will not be called for your booster vaccination until you are over 6 months from your sort of second dose. And I think that is going to be an issue for members of the public. So again, we need to get our communications right, because now that the government has offered that, and we are offering a booster programme to the over 50s, people's expectation is that they can just pitch up and come along and have it. And it is very clear that there has to be a 6-month gap between their second dose and the booster dose.
Okay.
So we will need to work on that locally. So I'll probably leave it there because I think that's probably the update. The other thing, Chair, that I will just say is that we have worked really hard, and Nadia and the team at the council have worked really hard to do the pop-ups and the sort of vaccination bus pop-ups. And I know that both Chris and I don't know if Helen's still here. Yeah, Helen, we have done a significant piece of work with our mental health population who attend outpatients at Claybrooks, and I know that that has gone down very positively, and I think we've increased 12% on those numbers, which were very, very low. So I don't know if Helen or Chris wanted to add anything to that.
Yeah, no, I think I think this is an on-the-ground ICP piece of work. So you might read all the papers and see what we're doing in mental health, but this is a practical example of what we've done in recent weeks and months. We would not have done this without the benefit of the partnership. So we've been able to agree to get the bus parked up on the Imperial Hospital site for the last, I think it's probably now 4 or 5 weeks. We probably had a missing week. And it's been so important. Our people, patients with serious mental illness, have a low vaccination rate. It's in the 50s, the upper 50s maybe. As Sue said, with only 3 weeks of the bus being there, we think that we got to 12% of our unvaccinated patient population. And I think from a perspective of one of our clinicians, from an engagement point of view, it's been really fundamental to have something that's been opportunistic, but also accessible in a predictable way to our client group. And this is the really important thing about it. The fact that it's been there every week at a set day and time has been key. And engagement of the client group around vaccination does take time and will continue to take time, and it will be ongoing for some while. And there was a particular patient whose incredibly isolated due to severe agoraphobia, and realistically will take several weeks for him to get used to the bus being there, be safe with some of the mental health professionals who are relating to him, to form a safe relationship before he will agree to have the vaccine. He's a smoker, he's in his late 50s, he has a poor diet, and so it goes on. So this is just one individual, but there are a lot of individuals in that category who need their vaccination and booster. So it's really an excellent example of how we've been able to, on the ground, actually work in a very integrated way just to get a simple thing as the bus parked on the Charing Cross Hospital site, so that some of the patients with serious mental illness have been able to benefit. So it's been really key.
That's very encouraging. That's very good. I mean, it shows those buses we found absolutely brilliant in getting people, bringing the vaccine to people, which is why it's good news that we've got, whether it's 7 or 11 more or 10 more pharmacies coming on stream, because people are so close to people and make it easy for them. We've still got really poor vaccination figures though overall as a borough, and it's depressing. And what I would hope is that we would be having endless buses and endless pop-ups. Now, particularly now that we've shut the we've had to shut the Novotel, and where are they?
So can I come in, Councillor Coleman?
Yeah.
I mean, this is something that both myself and Sue have raised with North West London as a massive risk. As Helen's just outlined, the benefits of taking the vaccinations to people. You know, even if we only got 10 people vaccinated in a day, it's 10 people who previously weren't convinced. The problem we've had is that since the JVCI decisions have changed, that the COVID centres have closed. I mean, Sue will correct me if I'm wrong. We've also now had to support the vaccinations of 12 to 15-year-olds, as well as the flu boosters and all the sort of housebound people, people over 80, people in care homes, etc. Although, to be noted, our care homes have been done by our GPs, which we're very grateful for. In reality, what's happened is we are now really restricted in the number of vaccinators available for the
We haven't got enough people to give the jabs, is that what you're saying?
We haven't.
Why not? Why haven't we got enough people?
So if I just come in, so obviously what the North West London team are doing, and there has been a bit of a gap in this, is as the mass vaccination sites are closing down, they are recruiting whole-time equivalent, staff to act as roving teams. And obviously the call on roving teams will be increased. The inner boroughs, so ourselves and our colleagues in sort of Western Central, have been fortunate in that we have had a bit of a monopoly on the staff coming to sort of support the bus and the other pop-ups that we've done. And we had a really good relationship with the mass vaccination site down at the Novotel, which was operated by Imperial. So Linda and I are lobbying for this. We have a strategy call. We have, an opportunity to talk to Juliet and the team at North West London. So we will continue to lobby, and we will continue to push to get the increased number of pop-ups and the vaccine buses.
How many have we? That's very helpful. How many have we got? How many of these vaccinators have we got in this roving team for 8 boroughs of 2.3 million people? How many have we got?
So I don't know how many we've got at the moment. I think they were looking to have about 100 whole-time equivalents on the team across.
100 whole-time equivalents. So that's what, 12 per borough.
That's still quite a lot of vaccinators to have for pop-ups. Don't forget we've got the 4 PCN sites as well. But just I guess the point that Linda and I would like to make is that we are trying to lobby.
I know, I understand that. No one's doubting you're pushing away, Sue, and well done. And Linda, appreciate that. It's worrying. We haven't got enough buses. We haven't got enough vaccinators. What about, I'll bring you in, Meryl. I want to just one more question, because it was touched on the last Health and Wellbeing Board, and you've just touched on it, both of you, in passing. What about vaccinating people at home? What's happened to that? I thought that was going to happen.
So we were looking at that in relation. So we weren't. So one of the key things that we needed to identify was, use Linda's phrase, taking the vaccine to people, as opposed to house, because they are very different to housebound and people that cannot get out. So I think one of the things that we need to differentiate, so we were looking at a cohort within a particular practice to see if we could do a bit of a test to see whether or not that would work. We haven't progressed that because unfortunately we've been inundated with all the other things operationally that we've had to deliver around bridging hotels, mass quarantine hotels, etc. So we are a little bit delayed on that, but we will continue to look at it from a practice perspective.
I just think you have every time you have the chance to sit and breathe, something new gets thrown at you, and I think we understand that and we appreciate that. For us all, we all wait for the next thing to happen. Anyone who likes fizzy drinks is worried at the moment. It's just, it doesn't ever seem to stop. But NHS North West London knew that the vaccine hotels, vaccine centres, Novotel, was going to be shut. It knew the contract was coming to an end. It knows that this borough has among the lowest vaccination figures in London and the country. It knows that the buses are what works. And we don't have, and I appreciate what you're doing, but what more can we do as a Health and Wellbeing Board to send a message to NHS North West London that we're not getting what we need as a borough to get our people safe, make our people safe? Is there anything else we could be doing as a board?
I think we're doing everything that we can do as a board. I mean, we are escalating it on a weekly basis, and it is referenced. So I think one of the things that, if we focus on some of the positives, you know, the fact that we have got additional pharmacies coming through, I think that is testament to say that actually our lobbying does work. So we will continue to lobby for
That's good, and I've been part of that team, so I'm happy to say that our lobbying works. I've been written a stroppy letter, along with other people, to make that happen. But Lucy, sorry, I'm going to bring in Meryl, but I just want to, without losing this point, Lucy Richardson, you're still with us, will you? I don't know if you can hear it.
Yes, I am. Yeah,
great.
Yeah, I can.
Lucy, you chair the Health Policy and Accountability Committee. I wonder if you would consider, I think you're going to be talking about COVID at your next meeting, but if you could really focus hard, as we're doing today, on performance, because you're the next opportunity for the public to explore exactly what's happened and what's happening. You know, Sue and Linda are pushing for these extra resources. You're going to be the next point of call, if you want, for the public to see whether they're being delivered and whether we're getting there. So if you could take this forward at your committee, I'd appreciate it.
Yes, no, we were definitely, that's on our agenda. So thank you. Yes,
that's really helpful. Thank you very much. Meryl.
Yeah, I mean, Ben, what I want to say is just to support exactly what you've been asking about. It's quite shocking, really, that these small number of inner London, particularly inner London, but Brent to some extent, boroughs of northwest London are the worst or almost the worst in the whole country. And there's no clear explanation for that. I actually raised this question last week at the Imperial Health Trust Board, and because there are implications for Imperial as well if it leads to more patients requiring urgent care at the hospital, and asking for constructive ideas. And their own view very strongly was that one needs to move away from a general approach to what they called hyperlocalism, which included, which they said was almost a street by street approach, and not necessarily one where you were going street by street initially with the vaccine, but street by street, actually talking to people who were refusing the vaccine as a way of preparing for the vaccination. So I suppose, you know, I think those approaches need to be looked at, but also the possibility of doing further work with people from Imperial. And as I understand it, Julian Redhead is probably the person that's taking the lead on this. But the situation in Hammersmith and Fulham is not just disappointing, it's frightening.
It is very, very concerning, yes. I agree with you. That's helpful points. I saw Linda's hand go up and then Sue's. Linda?
Yeah, thanks, Meryl. I think the conversation we've already had, and Dr. Lang may want to come in, because we actually had a conversation with Julian Redhead exactly about that point. In fact, Nikki did go street by street to talk to some people, and she may want to talk about her findings there. I think, but fundamentally, we have actually really tried to get into communities. We have done door knocking, we've done leaflet drops. I think fundamentally, this is not just about vaccination though, Meryl. It's not just about a fear of an injection. And it's something that we're taking up at both an ICP and an ICS level, and Councillor Coleman and yourselves were involved in the rapid improvement cycle. This is about a lack of trust. And that's a piece of work that we've got to build on now, because no matter what we do, we have a cohort of people who do not trust either ourselves, the NHS, the actual the research, etc. So I think we're very committed to doing a number of approaches at the same time, and you know, that includes our flu vaccination. But we have to accept that we have a cohort of people who do not want the vaccine. And I don't know, Nikki, do you just want to briefly talk about your experience? Can't hear you, Nikki.
Now, you're not on mute, but we can't hear you. While you look for that, Sue, did you want to add something?
I was going to agree with Linda in the sense that we have also been sort of very hyper local in terms of the amount of contact that we've had with patients and sort of local residents in terms of encouragement to come and get the vaccine. And yeah, there is a cohort that just do not want the vaccine, and we can't mandate that in any way. We can't force people to have it. But we are looking at sort of all of the other ways, and certainly from a local authority perspective and from a health perspective, that work that Bob Claver undertook in that sort of rapid improvement, I think, you know, that's the bit that we need to sort of pick up and see what the lessons are.
Thank you very much. Nikki, did you want to come in? Is it going to work? If it doesn't work, don't worry. No, we can't hear you. We'll have to leave that. That concludes the formal part of the proceedings. I just want to mention a couple of things though for looking at the future work programme and pick up on something that's been we've just been talking about. What's come out, we talk a lot about learning from COVID, and we talk about learning from COVID, but what's just been touched on is one of the, there has been some learning, but there's also just been finding things like we've been working better together in a way which we don't want to lose. So we've learned that actually can happen and it can be better. One of the big learning things for me has been how many people, particularly from a Black African, Black Caribbean background, are reluctant to be vaccinated. This is not to blame them. This is because and I'm a white liberal man who thinks everything's been getting better, and this has been for me one of the biggest wake-up calls of the whole COVID pandemic. It's been the canary in the coal mine that you have so many people who are British citizens and just happen to have a different colour, and because of their life experience and the people they know, do not have confidence and trust in the NHS. And we've been discussing this a lot, not in terms of, oh yes, let's put the problem right by persuading them all to get vaccinated. That's not the problem which has thrown itself up. The problem is that there is a lifetime of experience which has led to people being reluctant, in this case, to have the vaccine because of the way that generally they perceive the NHS and the treatment they've had. I think this is big. This something just shocked me hugely, and perhaps I'm just showing my naivety there. So we've been discussing this a lot at the ICS level, at the level of the 8 boroughs and the NHS together. And it's been some really good, the beginnings of a good conversation. We are very far from the conversation is beginning. It's begun positively, and the work that's been done in 10 groups of people came together from across North West London just to engage on these issues. Workshops has been tremendously helpful. NHS North West London has now acknowledged formally, and it will be publishing this in the next weeks, that acknowledged structural racism in the NHS in North West London. I do not believe it is only in North West London, but we are only in North West London, so we can only deal with North West London. I think it's tremendously helpful. It's not a matter of telling each other off. It's a matter of recognizing an issue and then being determined to do something about it. It's also recognized that the only way that we're going to tackle this structural racism is by reshaping services, shaping services directly with people themselves, which talks to a lot of what we've been addressing tonight, and talks to a lot of what the ICP wants to do and merrily been encouraging other people. You can't turn around people's, you can't turn around people's lack of trust and lack of confidence in 5 minutes. You can only turn it around by really engaging in a way which has not been done before, from the bottom up, and by shaping and changing the way services are delivered so people actually see their engagement has a purpose. Not another report which is produced saying how bad it is about the inequalities in the NHS and inequalities in the country, which gets put on a desk somewhere in a drawer and not actually acted upon. I think there are at least 7 of those by my reckoning, which nothing's happened on. So the fact that the NHS has now acknowledged structural racism, that it's finalising the beginnings of how, and we're now thinking about how to have the conversation, so it's not just a group of white people at the top of the NHS and the council saying, well, this is what we think, what do you think? But having a completely different way of having a conversation. I think, Linda, you put it, we're talking about this with a group of residents next week, and building trust, the start of a conversation. And I think, or later on Friday, and Jazz, I hope you're coming to the meeting. You've been invited. I think you may be coming. But it's how we talk to people and how we change the way we deliver services, whether it's council, but particularly in this case, NHS services. So we respond to the lack of confidence, the lack of trust that the vaccine reluctance has shown us. So it's not about getting lots of people vaccinated. It's about recognizing the racism that exists out there still and that's causing people to get second-rate treatment. So what I'd like to suggest is that we will be further advanced in North West London on this path at the next meeting. And if you're happy, I'd like to put tackling structural racism as an item on the agenda for more discussion at the next meeting. Would you be happy for us to do that? Yeah. If anybody thinks that wouldn't be useful, do let me know. But I think that's going to be very interesting. I'm making it sound very grim. It's actually recognizing what's going on is kind of shocking and upsetting. But the fact that we're determined to do something about it is cheering. I think it's the proof of the pudding is going to be in the eating, though. That's the first thing. I want to mention, Lucy, did you want to come back on that point?
Can you hear me?
Yeah.
I wanted to mention the elephant in the room when it comes to changing perceptions and the very good work we've heard from Dr. Lang about doing workshops and engagements activities. But my question is, how can we, North West London, make sure we secure the funding to make sure these consultations are ongoing? Because as you said very eloquently, that it can't just be a series of short workshops that finish. It's got to be work that's really deeply embedded. And I know that Brent have been doing some very exciting ongoing work, far-reaching work with this. How can we secure the funding? How can we secure the funding for housing?
You know what? I'm not worried about the funding at this stage. I'm really not. I'm not. I mean, I think it's really important to think about it, and we do think about it. I'm not worried about it at this stage. I'm worried that we're going to go and get the conversation wrong. And I'm worried if we don't actually shape it. We're talking, for example, we have a race equality group at the council who 150 people come along. We have some fantastic people leading that. I'm talking to them. We need to, Jazz is going to it, but we need to work out how to have the conversation, and it isn't expensive necessarily if we do it in the right way. It's just we don't tend, whether it's white or black or whoever, we don't tend to talk to people always in the right way. And this will have lessons which go beyond the issue of racism, I think, and how we work. It'll also have lessons because the ICS is going to set a framework at the top, and the ICPs in each authority, in each area, are going to be able to deliver this in a creative, flexible way. And that's also going to be interesting for the way the new ICS-ICP relationship works and clarify who is responsible for what. But your point about funding is always, all points about funding are well made. I'm not worried about it at this stage. because I think there's going to be such enthusiasm for people themselves to organise events and get together and have discussions, and we won't need that much resource. But maybe I'm an optimist. Thank you for making the point. So we'll cover that in a future meeting. And the other one I just wanted to raise is I do think we should be talking a little bit more. We've touched on it in past meetings, but it's becoming is long COVID. I'd just like to understand. I think as a borough, I think we'd all like to understand better what we're finding, what the situation with our own residents, and what we're doing as a borough to try and support people with long COVID, and what more maybe could be done. I think that's an issue which we touched on, but not got into any great detail. James, do you want to come in on that? Sorry, you flashed up for a sec.
Yeah, no, certainly I do. I'm involved in long COVID work in North West London, and we have been working quite hard really since it became obvious that this was part of this phenomena of the pandemic. And we have a community and we have a hospital-based service. And what we have found is that the projected incidence of long COVID hasn't been as high as we initially feared. So there is, at the moment, well-funded work in the community and in the acute trust to help patients who are presenting potentially with long COVID. The thing about long COVID is it is a whole set of symptoms, and our knowledge about it is emerging. But there is work in place, and there are services in place.
Well, good. I mean, it's a really helpful sort of quick oversight. If you come back and we could talk more about it at the next meeting, I think even if it's to provide reassurance, but also, so we can also have to get a bit more detail about it. I think
I'd be glad to.
That will be helpful. And my sister still hasn't got a sense of taste back, but I don't blame you, James.
Did she have good taste before she became unwell?
What, in clothes or no? Yes, no, she did. She had perfectly good taste. Now she could taste everything perfectly well. And now she can't. It's been months, but she's just, I'm just saying that's not destroying her life, she tells me. But I do think long COVID is much discussed. People raise it with me and with us. So let's at least put it on the agenda and have a proper conversation.
To be clear, for a small number of patients, it's devastating. So we have to keep it on the radar.
Yeah, excellent. Well, thank you very much for that support. Is there anything else anybody else thinks we should be putting on a future work programme? Which we haven't already covered or committed to doing? Okay, we've covered Jim, I mean, sorry. Silent, you're on mute.
Sorry about that. One thing we've touched on several times during the evening, and that's GP services. We know GPs are under enormous stress. We know we're short of GPs, and we know that we've got a changing population. Post-COVID, there may be things we've learned about how the interaction between services and population, and that's probably worth thinking about because we know change there it needs to happen.
It's very helpful. In terms of the next meeting, it'd be a big. I can see that being a big subject for discussion because it's fascinating and there's so much that it encompasses. So I think possibly not the next meeting, but I would support. And would anybody else think it's not useful to have a discussion about GPs? We're talking about future GPs, how people in the profession access. There's quite a wide range of issues. And we need to define what we're talking about a bit as well, James. I see Jim. Because you're both next, but you'll be glad to hear on my screen you're right next to each other in a little bubble.
Hi, Jim.
Yeah. So yes, let's put GPs. Let's find the right way of framing it, Jim. If you want to have a bit more thinking about what that might mean, but let's have a discussion about GPs. That would be helpful.
It might be helpful not to call it GPs. It might be helpful to call it primary care.
Yeah,
in reality,
nobody outside this room thinks of it as primary care. I suppose we can educate.
It's just the vast amount of patient contacts. The majority of patient contacts that actually happen in GP surgeries are with all kinds of people: pharmacists, healthcare assistants, receptionists. It's a broad group of workforce. So I'm very happy to come here and discuss the complexity of that service.
Should we talk about GP surgeries?
We can, yes.
Yeah, rather than just GPs, because I don't think, but also that's a helpful distinction already. All right, well, good. That's something we'll look at in a future meeting. We'll find the time to table that. Is there anything else that anyone would like to raise this evening? No. Well, I apologise for running a little bit over time. It happens when you have an interesting discussion. Thank you all very much. Thank you for what you're doing, and good luck with everything else that gets thrown at you and thrown at us. I'll see you all soon. Thank you very much. Bye.
Bye.
Thank you. Bye.
Bye.
Bye.